This is Heart Rhythm TV. We're at HRS 2024, and we are talking arrhythmias in the athlete. And I'm joined in the Heart Rhythm TV booth by Dr. Rachel Lampert from Yale. Welcome.
Thank you.
And we've got Dr. Eugene Chung from Mass General.
Thank you.
And these two fine individuals and members of our society really were responsible for this HRS-led document that is detailing very specific guidance on how to manage arrhythmias in the athlete. And that's important that we all know, that we all watch the tragic Buffalo Bills game with Damar Hamlin. We've seen what's happened to Bronny James, and sudden cardiac arrest is in the news and in sports. And sports cardiology is this evolving field. I myself am involved with the Phoenix Suns, and it's confusing and it's a high-risk situation. So we need this document. And I think it's great to be able to spend some time and tell us a little bit about the importance and the significance and give us some behind the scenes of what went into this.
Great, thank you. It's a pleasure to be here. So, I think what's really unique about this HRS consensus statement is that prior documents in the athlete have really focused on if an athlete can return to play. If you have this entity, if you have that entity. Our document really takes a different approach. Our goal, and we think what should be the goal of clinicians caring for athletes, is to try to facilitate their return to play. Most of the time, that's what they want, to get back on the field, back in the pool. And our job is to try to manage their arrhythmias in ways that they can do that safely as possible. Now, it's not always possible. There are some entities that are just prohibitively dangerous, but for the most part, data has shown that appropriately managed athletes can participate safely.
Excellent. And can you tell us a little bit about defining what who an athlete is? Do we meet those definitions here as who an athlete is and why it's so important to be studying this in athletes?
I'll only dare to speak for myself, Rod. I do try to play tennis every now and then. But so we want to take a broad approach regarding that as well. We often think of athlete as someone we see on TV, a professional team in a competitive setting, someone placing a premium on competition. But we also want this to be applicable to the athlete who's recreational, maybe the everyday athlete, even the weekend warrior, but may have an arrhythmia or potential arrhythmia. And so what's unique about taking care of athletes, while you can get arrhythmias that are in this document, whether or not you're an athlete, you may have an inherited condition or an acquired condition that leads to these arrhythmias. Something about athletic adaptation not only affects structurally the heart, but can affect the electrical system. And so that can affect any chambers of the heart. And on top of that, if we want to treat and mitigate symptoms, then sometimes the medicines are not as well tolerated or not desired by the athlete population because either they're relatively young and don't want to be on medicines forever, or they just feel like they're symptomatic with a beta blocker, for instance. On top of that, some patients prefer to be a little bit more aggressive initially, to have a procedure earlier than maybe someone who is not trying to get back onto a field. So we feel this document can apply to that particular population in ways that, with expert consultation, a healthcare team can help get patients with either inherited or acquired arrhythmias back to play.
Fantastic. So we have guidance now. I'm going to dive in and get a couple of the really high-yield salient points of what you want our viewers to know. I got to start out. Pro athlete, Major League Baseball player with atrial fibrillation. What do we do? And there's been some change maybe in guidance?
Well, I'll take that one. So everything we do is with a shared decision approach, but that particular patient may not be so keen to be on the medicine, and also may want something that may be potentially curative, and most likely is paroxysmal. The latest AFib guidelines recommend for the athlete population a 2A indication for first-line ablation. I don't like the term early. I think first line is more appropriate. And balancing that, the evidence that went into that guideline, the accumulating data of the benefit of what has been called early ablation in the general population, observational data in athletes, that athletes do just as well as non-athletes with AFib ablation, and then some of the other things I mentioned, the considerations of medicines and lifestyle with the athlete, that we raised AFib ablation to class 1 in this document.
Love it. Dr. Lampert, any other high-level summaries that you want our viewership to know about from this document?
Well, I think a couple other things to really bring out. So, we're talking about athletes with arrhythmias returning to play. And so the most important thing to be thinking about is, have we got whatever that arrhythmia is suppressed? So is the patient going to be safe as they go back? And, I think at the broadest level, where we talk about different types of therapies, ablation therapies, medications, but you really want to put that person on a treadmill. And when we're talking about stressing athletes, we're not talking about, your father's Bruce. What we're talking about here is really mimicking the type of sport they do if possible, or at least making sure that they're working, making sure that you've really exercised that person to exhaustion before you say, we're good to go. So I think that's one sort of broader level point we'd like to bring out as well. So for example, with a defibrillator patient, we're going to be thinking about that defibrillator patient about a couple of things. We're going to be thinking about what's their underlying disease, make sure we've thought about that. We're also going to be thinking about what type of device, given their sport, is transvenous better, subcutaneous? Do we need to be thinking about the newer types of systems? We're going to be thinking about how to program that defibrillator, how to program the pacemaker for a patient that might have heart block. And that's something else we're going to put that patient on the treadmill and make sure we really have got that device programmed the way we want it for them to go back.
Well, thank you for joining us on Heart Rhythm TV, and I know there's a lot of other people to thank on this committee.
Yeah, it was such a joy. We had a passionate, hardworking group that was really a joy to put this together.
Total team effort and a lot to read, a lot to review, and thank you for the guidance, because every time this comes up, it's like, it's such a high-risk, high-reward situation, and we're always in that area where sometimes it's data-free, and that's where guidelines are the most important. Thank you so much for joining Heart Rhythm TV.
Thank you.
MS.